will introduce you, my speak is in the around sleeping sickness and the development of DNDi in this disease and the progression of our development. So sleeping sickness is a sub-Saharan disease. It's mainly located in Democratic Republic of Congo, which is here and in yellow is one clinical form of the disease, which is the Gambiense, which is the most important strains and the disease in the sub-Saharan area. It is the reservoir of the Gambiense is human, and the vector is the tsetse fly or the Glossina palpalis for this disease. And you have also another color here in the blue, which is the other form of the disease, which is the Rhodesiense disease, morsitans, which is the tsetse fly. This is the reservoir is human. In this graph, you can see the progression or the evolution of the disease since 1 century. At the beginning, it was a very high number of patients infected by the Gambiense, and then it was a decrease due to the activity of the colonial disease control program. It was in the 16th, it was quasi eliminated, and then they stopped all the screening and it increased again, and WHO involved in the 19th with all the partners to work again on this disease, and we are on the way to decrease again the number of cases. The difference between the disease is here. I put you here a small picture I took from these publications. The difference in the two strains is, in fact, Rhodesiense and Gambiense was able to generate or to create a resistant gene in the human normal defense and lead to the disease. We have to deal with two parasites, two stages. So far, there is no vaccine for this disease, and the diagnostic is complicated. And I will go to this in the next slides. A rapid picture of the clinical signs of the disease. We have two steps. The first step is blood or lymphatic. The parasite is circulating in these two vessels, and then it crosses the blood-brain barrier and infected the brain, and we have this classic signs as sleeping disturbances and neurological symptoms. The duration of the disease is different between the two clinical forms. It seems longer in the Gambiense as in the Rhodesiense, but the Rhodesiense is much less followed as the Gambiense, as there are less cases. Regarding epidemiology, you see here in this graph the huge decrease of the number of cases. This is due to the activity of WHO and the partners. So in 2020, the target of the Gambiense disease was elimination of a public health problem. It was validated in 6 countries. And for 2030, the goal is elimination of human transmission in 15 remaining countries. And here we can see, I will present you the input of Institut Pasteur now in this elimination. So the incidence is decreasing, and so far in 2020 we have more than 97% reductions in 2000, from 2000 on up to now. Regarding Rhodesiense, it's another difficulties because there are less cases, less concentration of screening and activities, and it is still a problem in 8 countries. And we wanted, WHO target is also to elimination of these public health countries. But recently, in 2022, in Ethiopia, where there was absolutely no cases detected since years, we have 6 new cases who has been detected, and It can be explained by the climate change. The population migrated from the mountains or into the field, and due to decrease of availability of water, and the cases comes out in these regions. And we have also seen an increase in Malawi since 2019. Here a picture of the treatment since the last century. As you can see, the main change, there was, since 2009, the main treatment was melarsoprol, especially for rhodesiense, but also for gamiense. And melarsoprol is an arsenic derivative, which was difficulty for the medics to use it because they know that there was a mortality due to the treatment. And therefore, there was a research to see how we can improve this treatment of these patients. Then we started with eflornithine, which is an infusion treatment. The first approach was a long treatment for 14 days, needing 4 times a day infusion, 56 infusion. It was a huge work and difficulty to treat these patients. In 2009, ENDI involved, and we was able to, with the help of MSF, to bring out a new treatment, which was a combination with this eflornithine plus an oral drug miflornithine, reducing the treatment for 10 days, but still hospitalization. In 2018, we introduced fexinidazole, which is a nitroimidazole compound. It's an oral compound, but still 10 days treatment with food, which need also hospitalization of the population, of the patients infected. And now we are working on a single administration compound called acosiborol. It's a single dose, oral dose. And I will show you some results we obtained with this drug. Regarding rhodesiense, we are still in a difficulty of treatment because so far the only drug available is melarsoprol. It's still used. It has good results, but still the same difficulty, safety difficulty. We are hoping to obtain this year, end of this year, or perhaps beginning next year, the approval of fexinidazole in this treatment too, but it's still complicated to have a good treatment for this disease. Now let's go to acosiborol. This is the new drug developed by DNDi. So I will bring you rapidly in the information of this compound. It's a small compound. It is an oxaborol 6-carboxamide derivative. It's a new family of compound. Small compound, a lipophilic compound, well tolerated as it is neutral in the body, high protein bound, very good safety, long half-life in the human, which gives us an interesting work of this compound. But the weak point is here. We have recently detected in drug-drug interaction. Acosiborol has a strong inhibition of cytochrome 2d6 and a strong induction of cytochrome 3a4, which needs to lead for more precautions as planned in the treatment of the population. How it works? Here we have I put you two graphs here. The first graph is the results of the activity. Here is the killing curve. Each line represents a dose, and each dot on each line is the calculation of the survival of the parasite when they are submitted to a certain dose. So we can see that this compound is concentration and exposure dependent. The activity is concentration and exposure dependent, and that is fine regarding regarding the long half-life, it helps us to have a good hope that it works. And recently also, Richard has published the activity of the compound, the mechanism of action of this compound. This TB Brucei specific activity by the blockage or the cleavage on the CPS factor 3, which is the elongation factor of the RNA, and block the activity of this and block the survival of the parasites. And this is so specific of the TB Brucei, and some other publications have been issued giving us good hope that there will be very low resistance in the field of the parasite to this compound. So very rapidly regarding the efficacy we have seen in our first trial, which is the pivotal trial of in the field. A few number of patients have been included, 208 patients, but it was well defined as we have a video recording of the trypanosome. 2 stages of the disease were included, the early stage and the central nervous system stage of the patients, more patients in stage 2. We have very good results in the stage 1 and very good results in the stage 2, 95% for the ITT population and 98% of success in the evaluation population. We have 3 failure was detected in this study, and we are working on this 3 failure. Here, just a forest plot to show you the comparison between the reference treatment NECT and acoziborol, and the red line gives you the results of the studies in these patients, comparing to the previous studies that has been conducted in these patients. And you can see 95% is very, very high results of a single administration. Here, rapidly, the safety profile, it's very well tolerated. We have a good collection of the adverse events during the study, and we have only 30% related to the compound, so it's very low, very well tolerated. The most frequent adverse event was very common adverse events, no real adverse events of concern, and the detection of the adverse events was only at the early introduction of the compound, and then during the long half-life of the compound, we have no adverse events. This you can see here in the publication below. You can see it was published in the Lancet, and it has a high repercussion in the media. So you can find more details in this of this study in this publication. What is our main goal now regarding this disease is, can we change the paradigm of the disease to see if we can treat earlier in the population before they go to the stage 2. So with this single administration, we can hope this approach. So in a nutshell, the current strategy is hospitalization of confirmed cases and need a large scale screening to be sure to detect the patient. The future strategy is continuing the screening, which is very costly, and it's complicated to do it, and to go to the suspect, that means serological positive population, and to develop, in fact, in the future, how we can have a good surveillance lab capacity for surveillance of this population. And of course, the last strategy is to go for the elimination of the disease. To go in this field, we have conducted a new study, which in this serosuspect population, which was a double-blind randomized study versus placebo, because this population are not parasitological positive; they are just suspect. And in this study, we have included 1,200 individuals, randomized 3-to-1. That means 3 active or 1 placebo. In this study, the Institut Pasteur in Guinea and Paris has a huge impact because they do a lot of sampling to detect the parasite in different approach, a new approach of detection of the parasite in the skin by skin biopsy, and to use extravascular identification of the parasite, especially the Gambiense. And the aim is, can we have a good information on the prevalence using skin biopsy or skin test, detection also the parasite in the skin and in the blood, and how we can take, with this approach, a new benefit of acoziborole. Here is the impact of Institut Pasteur. You can see the huge amount of tests they are conducting. Actually, they are finishing their work so far. So we have 730 subjects who have participated in this sampling. It was conducted in 4 sites, 1 in Guinea, 3 in the Democratic Republic of Congo. There was 2 time points, enrollment and follow-up at 4 months, and a lot of sampling in blood and in skin. The blood test was venous blood and dry blood spot, and all these tests are conducting, and we hope that Institut Pasteur will bring us a simplification of the diagnostic of the disease. So what is going on in the future? We have another study which will start next year called Stroke AD study, which is a screen and treat study. How can we, the aim is how can we treat the population or the seropositive population as close as their home living, avoiding any hospitalization of the population. We will also conduct a study in Rhodesiense with acoziborole, and we will start with in vitro time to kill investigation to see if this drug is as efficient in Rhodesiense as in Gambiense. We also developing a pediatric formulation for this compound, and we are looking in the future if we can include breastfeeding women in this strategy. So this was the overview of the sleeping sickness at DNDi and how DNDi is now involving in this main concern regarding climate change and environment change. So DNDi is focusing on 4 main target. The first one is to continue to the research of new compound in the disease, climate-sensitive disease. Also to look how we can improve our manufacturing and R&D research to decrease and to have a high environmental protection regarding this manufacturing. The third one is the climate change adaptation and focusing on how can we improve the access to treatment of the population as close as their living settings. And the last one is how to reduce our climate impact regarding the environmental footprint of the NDI. So regarding how we implement that in our R&D research is, of course, continuing to focus on the main disease we have so far starting with. So sleeping sickness is on the way to come to the end of the research, as we have a good now single administration. Leishmaniasis is a difficult compound, a difficult disease. We have now 5 new short course treatment under development, and we hope that we can certainly have someone coming out in the next future. And also we are looking on combination, if combination can help us to treat this disease. Chagas disease is also a concern of the NDI, how we can improve the treatment of this disease, and how we can detect as early as possible the population and treat them with new compounds. Filaria and river blindness, we are focusing on an adult filaria worms, to kill adult filaria worms instead to kill as is done with ivermectin. So it's a huge difficulty. It's difficult to conduct the clinical studies in this type of target. And the two new diseases we are focusing on is dengue and schistosomiasis, looking to get for schistosomia access to treatment, of the new treatment, and dengue to repurposing existing antiviral drugs. So this was my talk regarding the impact of the NDI in this infectious disease in Africa, and I thank you for your attention.
Thank you very much. You have any question from the floor? So I have one question. So for this trypanosomiasis, do you have any prevention?
It's a very good question. The idea of the prevention is complicated to do it because it's difficult to demonstrate the activity of a prevention with a new compound. So, you know, the main distribution of the disease out of the sub-Saharan African country is Rhodesiense, because it's an infectious, it's an animal reservoir, and the population, the human, are infected because they are traveling in the parks, wild parks, and the main reservoir is wild animals. So if we can demonstrate the activity of in Rhodesiense, perhaps we can imagine to have this possibility to make a prevention, but this is in the next future. So far, we cannot demonstrate that it is very interesting to have this type of target.
Okay, thank you very much. So I think we learned a lot today about this disease. Thank you very much.